Hi there. Welcome to The Preventable, the podcast giving you a seat at the table with conversations about the intersection of alcohol, drugs, and mental health in everyday lives. Take a seat and join us.
Welcome to The Preventable, and that's the name we've decided on, so we're going to just stick with it. We went back and forth about, which emphasis do you put the syllable on, so we're going preventable.
Nice.
With me today is Dr. Cunningham. I had to pause because she just got married. Congratulations.
Yes, thank you.
So if you're listening and you're like, Dr. Cunningham, who the heck is that? You probably know her by her maiden name,
Turner.
which is Dr. Turner Cunningham. And so, Dr. Turner, so are you hyphenating or we're just going full Cunningham?
Full Cunningham. Yeah. A little more conservative, just full Cunningham.
Like it.
Dr. Turner is the new Dr. Cunningham.
That's right. That's
Same
right.
person.
That's right. So, and you got hitched to Carl Cunningham, who is just like the coolest person. He's a sergeant.
Yes,
right?
for St. Louis City Police Department. And we actually met doing work around opioids.
Oh, look at that. It was like a match made in the field of service.
Yes, we joke and say, drugs brought us together.
Oh, yes. So full transparency, you are a member of our board, and we are so grateful for that. And you've been on our board now for a little over a year.
Yeah, oh yeah.
But even before then, we worked in the same spaces because you've kind of really devoted your life's work to making sure moms and babies in particular.
Yeah, I was like moms and babies, but I say mostly like the Black community.
Okay.
Yeah.
Okay.
But I've done, of course, like some advocacy with moms and babies, just like within the clinic, I feel like. But a lot of my work have been more so like advocacy in the Black community and then just kind of in the addiction medicine space in general. Yes. But it's pretty much like changing the narrative behind substance use. And that can be true for, I think, anyone that's dealing with substance use. I just know a lot of harms and hurt have been, definitely in the Black community, especially, we can't not talk about the effects of systemic racism when it comes to substance use treatment in the Black community. But I just realized like going through school, so medical school, residency, we're not taught this stuff. And like we're taught to take a social history. So it's a matter of how many cigarettes do you smoke today? Do you smoke cigarettes? Yes. How many do you smoke? Okay, a pack per day. Do you drink alcohol? So it's like we don't really get into the treatment and understanding this as a chronic disease. And it was really when I was a resident, two people who really helped me, Dr. Fred Rotnick, who is amazing.
I want him
to this day.
I want him on the podcast.
Yes, please do. But like he was he actually was the person who kind of like introduced me and got me engaged because it was initial work around, faith-based communities.
That's right.
Right. And when I was in medical school and in residency, I was doing a lot of work with local churches, Black churches, just in general preventable things like hypertension, diabetes. And they brought me in for this particular faith-based initiative. And I was actually really nervous about it. I did not know how the Black church was going to receive a message about substance use. It's tend to be this punitive and moral failing and, but honestly, the approach that I took was that medical approach in helping pastors and deacons and mothers to understand how I see this as a disease. And it started to they were receiving me. I didn't get any pushback. I think now
you
the crazy
doors.
Thank you. I tried, but I was so nervous about it. But now with harm reduction, that was the next part.
Can you clarify what harm reduction is in case people are listening and they don't know what that means?
That is true. So I love this. So it's meeting people where they are. And the root of it is, we want to save lives. And the reality is drugs are going to be around in our system, in our society. People are going to have access to them, but we don't want nobody to die, right? So how can we keep somebody alive? So it's counseling on how to safely use, how to use Narcan is just one aspect of it, how to test your drugs. And it's all rooted in, I want you to stay alive so you can come back and see me, or maybe go to your family member's house. It's a completely different concept. I think some of us that's in this space like have latched onto that idea. But for some people, it's quite challenging to understand that.
Well, I'll just be, really candid. I mean, that was a topic that Prevent+Ed, formerly NCADA, I mean, we were really slow to embrace.
Yeah.
Because we're all about prevention. So we didn't know that we could be all about prevention and really promote the idea of harm reduction.
Right.
They're not mutually exclusive.
Right. But in one way, you can say that it's preventing the potential harms that can come
it's
along.
A different kind of
right. It's
prevention.
a different kind. Right. But it's like
death prevention, but it's
right.
also like you need. We had a guest in here who was talking about that parable, the fence or the ambulance, right? And so you've got people coming downstream, and you're trying to like take the bodies out of the water, and nobody's really wondering what's causing, right? And so in reality, I think what we've all started to realize is that we need people upstream to try to prevent people from getting in the water in the first place.
Yes.
And we need people downstream for the people that are already in the water.
Yes.
It's like a both and. It's not an either or.
Right. I agree. So it's a huge lift. And I think introducing that into the clinical space is also new. I think for physicians or providers in this treatment space, it's either push abstinence, and I think now we're just making leeway with feeling comfortable using Suboxone, but this idea that somebody is actively using and are coming to me, like that's a pretty new phenomenon. And, I tell people that people who actively use, they care about their bodies. They want to live. And when I see people in my clinic, what does recovery look like for you? Maybe it could be, I'm not using IV, but I'm snorting, and that's a celebration. That's a win. And I think for some people in our space, it's more so that either or. Either you're going to do the Suboxone, Vivitrol, go to the methadone clinic, or go to counseling, or you're just not even going to come in here anyways. And it's like we're forgetting about, what about all the other aspects? What about treating for Hep C? What about discussing contraception for some women? What about getting pap smears, managing a hypertension? So I have quite a few people who work part-time. I have some who
and are still
and they are still
using.
And mammogram is up to date. Pap
we
smear
used
is
to
up to date.
Functioning alcoholics.
Yes.
Back in the day,
it was.
Like that term has definitely fallen out of favor.
Yes,
but,
right.
Yeah.
But it's like, but let's give people the opportunity to access healthcare services. But then also, it needs to be trauma informed and truly patient centered, and not a paternalistic view where we're telling you what you need to do. And I tell people, I learn a lot.
Paternalistic and a kind of a white supremacist
Yes,
view.
it is. It definitely is. It definitely is. And when people see me, I think they're so shocked when I'm like, okay, so let's talk about, if you were to use, this is what I want you to do so you can come back and see me.
Because they're assuming that you're a doctor and you're going to say, okay, do you use drugs? And then no. And that people are going to lie on those, screens.
Right. I spend a lot of like counseling up front, like letting people know that, not trying to discharge you. I understand, like, it's a chronic disease. There's going to be periods where you may just have a recurrence of use. That doesn't make you a bad person.
Nope.
That doesn't make, a reason to kick you out of the clinic. Like, no, that's not. And I used the example with the diabetes. You probably heard that probably a lot, or the hypertension, and if somebody's doing really well on their diabetic medications, Thanksgiving come around, and a lot of us have a recurrence.
Yep.
I love sweet potato pie. I love all of that.
Gosh, so do I.
And it's like, then you come back and let's say your A1C is back up to 9.9. What do I do?
Nobody's going to, chastise you and say, get out of my clinic.
Yeah, like,
you failed.
Right. Like, okay, let's revisit your treatment plan. Let's connect you back with nutrition. How can I help you? Let me increase your visits. And like, that's the type of model we need to adapt with this. And I know it's new, but I also push for more primary care providers to feel comfortable with this.
Yes, that's a huge. When I think of you, and I think that's why I thought moms and babies initially, just because when I think of you, when I hear your name or I see an email from you come across, in my brain, it's you at the primary care setting, helping families get comfortable talking about things because they're being asked and embraced, and the topic is being brought up by their
Yes.
primary care physicians.
Mhm.
And that is a whole change
Yes.
in mentality.
I agree.
It's not the in and out. It's the how can I help you as a person,
Yes.
flaws or whatever you want to call them and all. And we're going to do your PAPs and we're
Yep.
going to, check your heart. And, oh,
Right.
by the way,
Yep.
are you using? Like,
Yep.
what's going on there?
Mhm.
I think of you and I think family, which is
Yep.
why, like, it's so interesting to, like, start off
I
by,
love
like,
what I do. No, that's true.
and, like,
And,
now it's like,
I mean, that's true. So, like, my clinic is the first to offer this care in the St. Louis area on a primary care level. Typically, somebody had to see a high-risk doctor.
huge.
Yeah, it is. And at our clinic, we have a lot of women who have been coming to us for years. And, they've created these relationships with my staff. And then it's like, once you get pregnant, okay, now you have to see somebody else. And it's like, now, no, you can stay at our clinic.
Which
Now,
can be traumatizing.
It can be.
And it can be very off-putting that you've
Yes.
built a relationship with this person.
and then now go see someone else who
mhm.
may treat me differently. But I mean, I also appreciate the high-risk clinics here. I have formed relationships with them. So there are times where I need to send someone like, hey, I need you to see one of my friends at this particular
That's a real
location.
warm handoff.
Right, it is. Like, let me tell you what to expect. I know them. That's different. And so for me, it's so amazing. Then when you get to the delivery and you're there with them, they have the baby. It's just like, oh, like we did it.
Did you always want to be a doctor?
Oh, honestly, yes.
I can see that. I can see it because you're the type of doctor that, like, I want. You know
Aw,
what I
thank
mean?
you.
I mean, that would be weird. But that'd probably be weird. But
People ask me, it was so funny, like when I first graduated, I had people from elementary school and junior high, I remember when you said this during career day. I remember. And it's just like, oh my goodness, I didn't believe you remember that. But yeah, I take it so serious, but I love what I do and I love to create change. But my biggest joy for me is when I'm in the exam room and when I learn from my patient. I learn all the slang and lingo from them.
Why do you think I go back in the classroom every once in a while? I know. I gotta stay hip.
Yes, but I do. And it has its time. With COVID, I have to be honest with this too. With COVID, a lot of us have experienced significant burnout, physician suicide has increased. That's a very real reality. But overall, when I take a step back and look at, even in the midst of this, being able to save lives with talking about, boosting vaccine confidence, testing someone, taking care of other preventive care needs in the midst of a pandemic, it can be, very, you can find yourself just feeling burned out, but there's some satisfaction there too, knowing that, we had patients who initially would switch to telemedicine, no, I want to come in and see you. Just kind of like, you want to come see me? You want to come to the clinic? Okay, let's make this safe.
I mean, Dr. Cunningham, you know this. I'm certainly not telling you anything. And in the last couple of minutes, this is what you're doing is really changing the Black experience with healthcare.
Yeah, I hope so. I hope
because
to.
For so long, there has been a really challenging, distrusting relationship, rightfully so.
Mm-hmm.
And so you're trying, and I think succeeding, in making people of color feel more comfortable, be accepted, be trauma-informed, be preventative,
feel empowered
about making their decisions about their own life and their own health. I mean, that's really incredible. And what I don't want to do is I don't want to sit here and list all of the reasons why the relationship between healthcare and communities of color has been so bad. I don't want to do that. Exactly. But what I am interested in is, what do you think people listening can do to keep moving forward in their own doctor's offices and with their own experiences? Even someone like me, who is a white woman. I mean, how can I be part of what it is that you're doing?
Oh,
I know.
That's a lot for 2 minutes.
I know.
I would say just be real. People can sense when you're phony. They can sense when you're biased. They can sense when you're just getting them in and out. Be real with people. That's the best thing you can do is be genuine and show up as yourself and recognize your flaws. Even as a physician, I've had to tell patients, like, you know what? I'm so sorry it took me so long to get back to you. I was in the hospital. And my patients appreciate that. And I just treat people as a human.
Do you teach other physicians?
I have, yeah. I've been doing a little bit, which is more so like opioid stuff, but that's the biggest takeaway I can say is be real, be genuine, and acknowledge, if you are a white person in this space, acknowledge that you may be coming to the table with some biases. You may have been socialized by principles of white supremacy and privilege, and recognize that, because that can show up with that Black person sitting in front of you, and they may not ever come back and see you anymore that's showing up.
And then what's happening to them? Yeah. Have you burned that bridge to where now they're not going back to see another physician? Are they, not taking care of their health because they have been burned so many times in the past? You have a lot of responsibility, and I know that you know that. And I am just so appreciative of you serving on our board, of your friendship, but also you stopping by today. So
thank you for having me. I love that we can just talk and not have to talk about data.
I know. When I invited you, I was like, I don't need data points. I don't need anything specific. I just want to talk about you.
Perfect.
So thank you so much.
If
you want more with Dr. Kanika Cunningham, or you want to learn more about harm reduction or recovery or equity, by all means, please subscribe, like, and review the Preventable podcast. Dr. Kanika. Oh, I almost did it! Dr. Now I'm confused. Anyway, thanks for coming.
Thank you.
Thanks for joining us at The Preventable, brought to you ad-free by Prevent+Ed. Prevent+Ed works to reduce or prevent the harms of alcohol and other drug use through education, intervention, and advocacy. Please visit their website at prevented.org. Like what you heard? Rate, review, and subscribe to stay up to date with what we are serving on The Preventable.